Thank you for the opportunity to present our abstract. I am Carol Mitchell, and I will be presenting on behalf of our research group. The motivation for this project was to develop an educational tool to assist with teaching scanning skills. We focused on developing an anatomic phantom that would assist with learning how to image the lower extremity venous structures with ultrasound. With the increase in the use of bedside and point-of-care ultrasound imaging, more medical and allied health professionals are using this technology. This ranges from a variety of medical physician specialties to medical students, advanced practice providers, and sonographers, both ultrasound students and practicing sonographers who are cross-training into the vascular specialty area, such as cardiac sonographers cross-training to learn vascular sonography. With this increase in ultrasound imaging for triaging patients, and it's used by many different specialties competing to get hands-on scanning time, there's opportunity to develop new methods of teaching scanning skills which are needed to better prepare all ultrasound operators prior to entry into the clinic. Simulation has been used in ultrasound imaging to teach basic scan skills and build confidence. Specific to the discipline of ultrasound imaging, scanning techniques can be focused and taught with a simulator to teach plane orientation, anatomic structure recognition, how to move the transducer between planes, such as moving from a transverse to a longitudinal plane. Simulation also offers opportunity to teach instrumentation skills. So teaching one how to use the ultrasound system they will be scanning to optimize B mode, color Doppler, and spectral Doppler images, and how to move between those different modes seamlessly. The objectives of this study were to determine the effect of the student ultrasound scanning skills using a lower extremity venous phantom, in addition to standard teaching methods of didactic lecture and scanning live volunteers, and to also determine the effect of the lower extremity venous ultrasound phantom in addition to standard teaching methods and didactic lectures as far as developing confidence in the student. And the phantom that we built, we had a power supply that was connected to a micro pump that pumped degassed water through a phantom that had a vascular venous anatomy built into a thigh component and then a calf component. The micro pump pumped the degassed water through the common femoral vein, greater saphenous vein takeoff, the femoral vein and deep femoral vein, the popliteal vein, and then the confluence of the anterior tibial vein, posterior tibial vein, and perineal vein. The phantom was constructed to also allow transverse imaging and the ability to perform compressions, which is shown in the upper ultrasound images. The image on the left-hand side shows the GSV, greater saphenous vein, and the common femoral vein without compression. The ultrasound image to the right shows the great saphenous vein and common femoral vein collapsing with compression, thus simulating the compression maneuvers that are used when doing a rule-out DVT study. The micropump supplied degassed water to the wall-less simulated vessels in the phantom so that color Doppler and pulse wave Doppler could be used to practice optimizing images. The image on the far left-hand side demonstrates the takeoff of the greater saphenous vein from the common femoral vein. In the upper panels, you see the common femoral vein in a transverse view, and then with the compression technique, it collapses. In the images below, you see the longitudinal color Doppler image of the common femoral vein with the greater saphenous vein takeoff, and then a pulse wave Doppler sample showing continuous flow in the common femoral vein. The panel in the middle demonstrates the transverse view in the upper panels of the great saphenous vein, the femoral vein, and the deep femoral vein. And then in the upper panel on the right, you see compression is applied and the collapse of the great saphenous vein, femoral vein, and deep femoral vein. In the images in the lower panels in the middle image, you see the confluence of the femoral vein and the deep femoral vein with color Doppler, and then the pulse wave Doppler in the deep femoral vein. The image on the far right demonstrates the calf imaging, and we see the popliteal vein and the takeoff of the anterior tibial vein, and then compression maneuver applied in the upper panels, showing that both veins collapse. In the lower panel, you see the confluence of the anterior tibial vein into the popliteal vein with the longitudinal color Doppler image, and then a spectral Doppler showing continuous flow in the popliteal vein in the phantom. And then this is showing in our posterior tibial vein, and this is the confluence before there would be division into the paired veins. And we actually were able to model reflux in the posterior tibial vein, shown in the ultrasound image on the left with the red flow. And then we were able to show how the spectral Doppler could be used again in the image on the right hand side, the lower panel. We're showing the perineal vein with flow below the baseline, and the color Doppler is blue. And then when we move the Doppler sample volume into the posterior tibial vein, again we're modeling reflex, you see the red color and flow above the baseline. 11 first-year diagnostic medical sonography students were recruited to participate in this study and were randomized into two groups. Group 1, N equal 5, received the standard curriculum. They were given a 25-point multiple choice pretest, a didactic lecture, and a 25-point post-test. During the lecture, a demonstration of the imaging protocol was performed by the instructor. Students then completed the pre-confidence measurement tool, which asked them to rate their confidence in performing 7 scanning skills associated with the lower extremity venous exam. Group 2, N equals 6, completed the same activities as Group 1 and then also participated in 3 30-minute scan labs using the Phantom. On day 4 of the study, all participants underwent a scan lab assessment where they performed imaging on a human volunteer model. There were no significant differences in baseline knowledge between the two groups. On day 1, the pretest score completed prior to the didactic lecture, the mean score for Group 1 was 10.8, the standard deviation 2.3. The mean score for Group 2 is 11.5, standard deviation 2.6, and the p-value between the performance of the two groups was 0.645, so not statistically significant. The post-test score completed after the didactic lecture, both groups improved significantly with a p-value of less than 0.001. There was no difference in the mean score after the lecture either between the two groups, with a p-value of 0.534. The mean score for Group 1 on the post-test was 18.6 with a standard deviation of 5.2, and the mean score for Group 2 was 20.5 with a standard deviation of 4.4. There were also no differences in how the two groups rated their confidence in performing the 7 scanning skills associated with this exam, with a mean score for Group 1 of 36.8, standard deviation 9.8. The mean score for Group 2 was 29.0, standard deviation 10.4. There was also no difference between the groups for any individual skills, with all p-values being greater than 0.05. Scan lab assessments on day 4 of the study demonstrated a significant difference in scanning performance between groups with a p-value of 0.019. Group 1 had a total mean score of 21.4 and Group 2 had a total mean score of 32.3. Post-confidence scores also demonstrated a significant difference between how each group scored their confidence levels between the pre- and post-scan lab scoring. Group 1 actually scored their confidence levels lower with a mean difference of minus 10.6 compared to Group 2, which scored their confidence levels higher after the scan lab assessment for a mean difference of 6.0. The p-value was significant at 0.026. Specific areas where Group 2 performed better than Group 1 in the scan lab assessments were scanning skills 2 and 4. Scanning skill 2 is the student is able to follow the venous anatomy from the popliteal vein to the perineal veins, posterior tibial veins, and anterior tibial veins in the transverse plane, performing segmental compression maneuvers. And scanning skill 4, which is the student is able to follow the venous anatomy from the popliteal vein to the perineal veins, posterior tibial veins, and anterior tibial veins in the longitudinal planes. Specific areas where Group 2 rated their confidence higher were for scanning skills 2, 3, and 6. Scanning skill 2 is the student is able to follow the venous anatomy from the popliteal vein to the perineal veins, posterior tibial veins, and anterior tibial veins, and the transverse plane, performing segmental compression maneuvers. Scanning skill 3 is the student is able to follow the venous anatomy from the simulated common femoral vein to the simulated popliteal vein in the longitudinal plane. And scanning skill 6 is the student is able to perform augmentation to show changes in the Doppler flow. It is interesting to note that Group 2 particularly scored higher both by the instructor who scored the scan lab assessments and how they rated their own confidence levels were regarding imaging of the calf veins, a skill that is considered more difficult by most sonographers. In conclusion, this study suggests that anatomic phantoms can be used to develop scanning skills, teach how to optimize images using system instrumentation, and build confidence in beginning learners. Future work will be to develop anatomic phantoms with longer calf vein segments, improve flow simulation, and model pathology. We will continue to examine how phantoms can be used as educational tools and explicitly look at how the use of a phantom may assist in teaching individuals to recognize normal versus pathological states and learn how to tailor the exam to answer the clinical question. Thank you for your attention. Please feel free to contact me with any questions.